And as Justin kind of works through trying to get on, I think we're going to go ahead and get started. And Joe Michael, if you don't mind, if you don't mind going first, um, in your presentation, would that be okay?
Absolutely, that's fine.
Yeah. So thank you all so much for being here. Dahlia, if you can move the slide presentation forward. First and foremost, I want to thank the team for being here today. It's myself, Dahlia, and Dot from Comment that are helping to kind of facilitate and make sure everything is working, as well as Sonia, who is in IT, that is helping from the back end. And so, Dahlia, if you can reshare and as she's bringing that back up, if everyone could just drop in the chat your name, your organization, and we are starting summer, thank goodness, although it's a little muggy, but I'll take it. What is the thing that you look forward to doing the most this summer? It could be anything. For me, I look forward to spending some time with my brand new niece. She's fresh, and so I'm excited to go and spend a lot of time with her. So if you could drop in the chat again, your name, your organization, and what you're looking forward to doing this summer. Oh, gardening, that's going to be fun. I don't know if it's going to be muggy, but you may be that kind of person that likes being out there. So, all right. So as we're getting that started, I'm going to ask Joe Michael to go ahead and jump headfirst into his presentation. He's going to be going over some of our pharmacy, doing a pharmacy overview, and we want to thank him so much for being here.
Well, Natalie, thank you so much for having me. I consider myself a little bit of a pharmacy nerd, so I'll just premise with that. But one of the things that I have just really embraced and loved doing since starting my position about a year and a half ago is doing my best to work with our stakeholders and just educating them on the pharmacy program that we have here at DMAS. As many of you know, Medicaid pharmacy is a super niche topic. There's not a lot of people who specialize in it, and so it can even be confusing for us. So it's totally understandable how it could also be confusing for some of our stakeholders. So I really think that these moments that we can be together and have a forum for questions are just very, very valuable. So thank you everyone for being. And also any questions at all, I'll be happy to answer. Natalie, would you prefer we do questions as we go, or questions at the end, or do you all have a format you usually like to follow?
If we can do them at the end, that way you may have multiple people have the same kind of question, and so we can pull them if we need to. But yeah, we can wait until the end.
Okay, great. So just to give a little background on myself, my name is Joe Michael Fusco. I am a PharmD, and I hail from the state of West Virginia, where I spent the first 6 to 7 years of my career working with the West Virginia Medicaid program. About a year and a half, I came on board at DMAS and started working on the state side with our program. And my title is the MCO Pharmacy Compliance Manager. So essentially, what I do is when I came on board, my main focus was the Common Core Formulary, which is our list of prescription medications that are covered. And since then, my role has kind of evolved to more of a managed care compliance role in the pharmacy program, meaning that I just kind of coordinate our 6 MCO programs, ensure they're providing consistent care to our members, and help them with any issues that they may have. I also try to act as a liaison to some of you, the stakeholders, into the pharmacy program, the agency, and then also the MCOs as well. So my position is housed in the Office of the Chief Medical Officer, and we have had some really exciting new members added to that team recently, one being our new CMO, Dr. Lisa Price-Stevens. She was previously with Chen Med, and I think she's maybe in week 2 or 3 with us now, but she's doing wonderful things so far, and we're just really thrilled to have her as a leader. And then who I directly report to is Marianne McNeil. She's a pharmacist as well, and she's the pharmacy manager. So a lot of you have probably heard the phrase that if you learn a lot about a Medicaid program, you've learned a lot about just one Medicaid program, because each state does things very differently. And part of that is staffing. So here in Virginia, we have a pretty small pharmacy staff. You'll see in other states, sometimes they have staff upwards of 15 to 20 people, depending on the design and configuration of their program. Aside from the pharmacy manager, there's myself. We also have Dr. Rachel Kane, who is our clinical pharmacist and our drug utilization review coordinator. And also we have Kiera Jasper, who is a pharmacy technician, but she's our contract monitor for our pharmacy benefits contract, which is through Magellan Health. We also have one additional position that's currently vacant. We'll be hiring for that soon. And that person is essentially our senior pharmacy policy person. So anything to do with the GA or updating pharmacy manuals, any new legislation that comes up, that person is generally responsible for that. So we're all kind of doing a piece of that right now, but that's our current setup. And I think we can move on to the next slide. So a lot of people are surprised to hear that the pharmacy benefit is actually an optional benefit. So the Social Security Act does not require states to have a pharmacy benefit as part of their Medicaid program. I'm happy to report that all 51 Medicaid programs in the United States do have the pharmacy benefit. Obviously, it's such an important and valuable benefit. But because it's not a requirement, they do provide an outline for if you do have covered benefits, this is what it should look like. And that is part of Section 1927 of the Social Security Act. It is a very long, detailed document. So I will save you all the trouble of reading it yourself. If you have any questions about it, please feel free to reach out to me after, and I can kind of point you in the right direction, or at least the right section in that document, which may refer to what you have a question about. So part of Section 1927 requires states, if they do have a program, to cover medications that are FDA approved, medically necessary, and they also have a requirement that the manufacturers participate in what's called the Medicaid Drug Rebate Program. It's also referred to as the MDRP. Now, I'll talk about that a little bit later and exactly what that is and how Virginia participates in that pool. Now, because we are required to cover these medications, that does not necessarily mean that we are not able to monitor or require some type of pathway. We're, of course, allowed to have prior authorizations and drug utilization review edits for clinical safety, quantity dispense, things of that nature. So we just have to have some sort of pathway to coverage for the medications on that list I mentioned. All right, next slide, please. So we also have exclusions. So, they say, this is what you have to cover, this is what you can't cover. And this list, like I said, is part of that Social Security Act. So number one being manufacturers that say, we're not going to interact with Medicaid programs, we're not going to offer them any type of special rebates, we're not permitted to cover those medications. And that is a very real-time process. So I'll just use an example. If Bayer comes out and says, we're not going to participate in this program anymore, we would actually have to immediately remove any drug manufactured by Bayer from our coverage. So it's a very real-time process. Thankfully, most manufacturers not only participate, but do so with enthusiasm, and they work really well with the state. So we're lucky to have those types of relationships. Another exclusion are DESI drugs, which I could give you a history lesson about this, but these are essentially drugs that were on the market before the 1960s, before the FDA kind of set up their efficacy and safety standards. A lot of these are things like hydrocortisone that's been around forever, hydrocortisone suppositories specifically, but you'll see those on the market still, and people use them because they've kind of been grandfathered on from previous use, but we're actually not permitted to cover those under our program. Drugs that aren't approved by the FDA, experimental, recalled, anything that's going to cause safety issues for our patients, we can't cover. And there also are some diagnoses that are excluded as well. So anything for anorexia, fertility, hair growth, or cosmetic, we don't cover any medications under those diagnoses. Now, there are some extenuating circumstances where we may consider those as comorbidities, but not necessarily as a primary approval. Next slide, please. All right, so as I mentioned, Medicaid Drug Rebate Program, MDRP. So essentially what the federal government said is that if we are going to provide funding and the states are going to provide funding for these prescription medications, we're buying them from the manufacturers, you have to offer us some rebate. And all the states participate in this program because obviously, strength in numbers. The more prescriptions you have, the more states that participate, the better price that we're going to get for those medications. This is also required for Medicare Part B as well. And I think we can go ahead and do next slide. Okay, so a big part of our pharmacy spend revolves around rebates. So just like if you go to the store, sometimes you'll get like a $10 rebate card that you have to mail in and you get money back from the manufacturer. It's essentially the same design for our program. So we purchase the medications at a certain price, and then we bill the manufacturers back for a rebate. And we do that, in certain increments throughout the year. But there are two different kinds of rebates. So we have federal rebates, which all states are entitled to, and every state kind of gets the same rebate. And then we also have what's called supplemental rebates. And supplemental rebates are in addition to the federal rebates, and those are generally negotiated on a state-by-state basis. So it kind of depends on how many people you have in your program, what are some prominent disease states that maybe disproportionately affect your population. Factors like that go into what types of supplemental rebates you can be offered. So both our federal and supplemental rebates are collected with DMAS and shared with the federal government according to the state's FMAP. So it depends on what our federal match is and how that's set up, but we do share those rebates with the federal government. All right, so as I'm sure you all know, Virginia does have MCO organizations. I think last time I checked, approximately 3% of our population was in managed care. We do capitation rates. Pharmacy is including that capitation rate. So that's that per member per month cost. We do that annually. We reconsider that capitation rate, and I think we make adjustments biannually. So the MCOs are required to provide the pharmacy coverage for our members in the MCO under that flat rate. If their cost goes above that flat rate, the MCOs assume that risk, and that basically allows the agency to have a more predictable budget. Next slide, please. Okay, so in Virginia, we have what's called the Common Core Formulary. So as I mentioned before, states do things differently. Virginia is one of the states we're considered a single preferred drug list state, meaning that we maintain one list of drugs and the MCOs are expected to follow that list. Sometimes in other states, you'll see, they might have 6 MCOs and 6 different formularies. They allow the MCOs to kind of determine what they want to cover. That's not how we do it in Virginia. So it really allows us to not only have a little bit of control as to what our members have access to and ensure that they have appropriate access, but it also standardized coverage between the MCOs. So we don't want someone maybe in Aetna to have a different benefit than someone in United. We want to make sure we have consistency across the board. This Common Core Formulary also is broken down into what's called an open class and a closed class. So we'll talk about specifically what those mean, but essentially we have those designations for rebate purposes, and I'll explain that a little more here in a bit. Next slide, please. So our closed class drugs, and those are indicated on our preferred drug list document if you've ever looked at it. Closed classes, we require the MCOs to follow to a T. So if we say we want these 5 drugs covered, the MCOs are required to cover exactly those 5 drugs. In open classes, the MCOs are not permitted to be any more restrictive. So if we say we cover 5 drugs, they can choose to cover 7. They can give an additional benefit. They just can't be any more restrictive. Next slide, please. So new drugs are coming out all the time. As many of you know, the pharmaceutical pipeline has just exploded over the past couple years. So because all these medications are coming out at such a rapid rate, we have to have procedures in place on how we're going to classify and cover those medications. So this kind of just shows a general algorithm of what we do, and I'll go through it for you. So first and foremost, because we can only cover FDA-approved medications, the number one thing that has to happen is that FDA approval. We then utilize what's called our Pharmacy and Therapeutics Board, which meets in March and September. This is a group of interdisciplinary medical providers that have been appointed to the board, and they sit and they look at medications that have come out and they decide what DMAS is going to do. I should rephrase that. It's a recommendation for what DMAS should do. So if the P&T committee reviews that drug, it gets put in one of those open or closed classes. With the open class, as I mentioned, the MCOs can be no more restrictive, so that can kind of cause some difference between the MCOs. And in the closed classes, they have to cover it exactly. If the P&T committee chooses not to review the drug at that time, then we are not permitted to cover the drug until that review occurs. And sometimes a delay in review is done for various reasons. It may be that we're awaiting an additional study to come out, or maybe there hasn't been pricing put out onto the market yet. So there can be a lot of different reasons for why the P&T committee may choose to delay a review. Next slide, please. So as far as our preferred drug list or our formulary management, as I mentioned, the Pharmacy and Therapeutics Committee, we also have another board called the Drug Utilization Review Board. The Drug Utilization Review Board is mandated federally by CMS. And essentially, it's interdisciplinary, just like the P&T Committee. But essentially what this board does is they look at drugs that we maybe already have decided we're going to cover, but we look at how can we cover these safely for our members. So that might be, this medication is not safe above a certain dose. So we need to make sure we put an edit in the system that will not permit patients to fill beyond the safe dose. It could be this drug interacts really poorly with another drug we cover. So we want to make sure that a member is not able to fill those two medications concurrently. And of course, any rejection, any edit that we put in the system is overridable. It just would require some type of intervention by either the pharmacist or the prescriber. And then, as I mentioned before, our P&T committee, they essentially look at our medications and decide how we're going to cover them and under what conditions. All right, next slide, please. So I always like to do this slide because a lot of people have been looking at our Common Core formulary for years, and sometimes it's hard to see the change. We try to highlight the document to show the changes every time there's a new iteration, but I always like to point out some big changes. So last year, we made all HIV medications preferred. So anytime a patient goes to fill, there's never any issue with access as far as a prior authorization. And we did that as a public health initiative. The same thing with hepatitis C treatment. We don't prefer all hepatitis C medications, but those that we do not require a prior authorization. Just another access thing there. We recently added hemophilia medications to our Common Core formulary. And when we did this, we got a lot of pushback from the community because, of course, who would want to restrict or put any type of restrictions on such a fragile population? But the reasoning that we did this kind of goes back to our rebates. If we want to collect a rebate on a medication, it does have to be part of the formulary. So what we did was we put all hemophilia medications as preferred. So now not only are we continuing to cover everything, but we're also getting that additional supplemental rebate from the manufacturer. And then probably the star of the show as far as changes has been the addition of weight management medications as of the first of this year as a class on our preferred drug list. So I'm sure you've read about them in the news. They're, every real housewife of every city in the country is on these medications. They're getting a lot of media attention. But at the base of it, what's important is that we recognize that weight management is important for our members. And it is a healthcare condition that we need to treat to make sure we have optimal outcomes for our patients. Now, we have decided recently to change the coverage criteria a little bit around weight loss medications, just to ensure that appropriate access is there. So more to come on that. There should be a Medicaid memo coming out soon on that. But if you have any additional questions on it, I can certainly answer at the end. Next slide, please. So as far as the pharmacy program, we don't only focus on medications covered and lists of medications and pharmacy edits and things of that nature. We also focus on pharmacy policy a lot. So as many of you know, before the pandemic, a lot of Medicaid members had some type of copay. When the public health emergency started, we no longer had pharmacy copays, and we actually received direction by the General Assembly to continue to remove those copays after the public health emergency ends. So no longer will you see those $1, $2, $3 copays at the pharmacies for your patients. We also started an initiative with the National SAMHSA group and also our addiction recovery services in-house to increase the dispensing fee for medications for opioid use disorder. And without going into too much detail, essentially, for those of you not in the pharmacy space, dispensing fee is basically the cost of the service that we give to the pharmacist for dispensing the medication. So they get reimbursed for the medication that they're dispensing, but they also get a certain amount of money for their services. That includes counseling, checking drug interactions, even down to the packaging of the medication and things like that. A big initiative in DMAS also is Cures Act compliance. So we're making sure that all of our providers are enrolled in our system and known to our system. And this is not unique to the pharmacy space. This is on the medical side as well. Some of you also may have heard some exciting news from the past General Assembly. We had Senate Bill 1538 pass, and that essentially allowed DMAS to amend our state plan, or directed us to amend our state plan to allow pharmacists to enroll as providers. Some of you may not know, but prior to this, only pharmacies could enroll as providers. So reimbursement will be provided back to the pharmacy for the service. And this is basically, this was an effort. It was not spearheaded by DMAS, but it was essentially an effort to allow a reimbursement pathway for pharmacists that are providing clinical services. So if you go into your pharmacy and get diabetes counseling, or you go in and you see your doctor and a pharmacist comes in after and talks to you for your medication, it allows a pathway for the state to say, here, we value your services and we want to reimburse you for the time spent on those services. And I think we can go ahead and flip to the next slide. Okay. So that brings me to the end of my conversation, or my presentation rather. I know some of you probably have questions. That was a lot of information in a short period of time. And I can assure you that was the abridged version. So I do apologize if it was a little quick, but I'm happy to take any questions you have at this time.
If you have any questions, you can drop them in the chat and we will make sure we pull them and make sure that Joe Michael sees them and is able to answer them. One question we already received is about the slide deck, and we always provide that either right before the meeting or right after the meeting. And we are going to do the same today. We traditionally provide it right after the meeting with any other supplemental materials that our speakers ask or provide during their presentation. So we'll do that as well. And that should go out by early to middle next week. So we'll make sure that happens as well. And if you're not receiving that newsletter, the link is in the chat. Joe Michael, I don't see any questions outside of that one. Is there anything? Oh, so I heard a presentation on weight drugs to SFC and limited to class 3. Could you please explain that further or discuss that in any detail?
Yeah, so I think you're referencing the Senate Finance Committee there, and I believe Dr. Price-Stevens did that, or at least was part of that presentation. I unfortunately was not there. But as far as limited to class 3, so I think, Cynthia, I think what you're referring to is class 3 obesity, which is categorized by BMI. So without going into too much detail, because I would like to wait for the official correspondence to come out from the agency, we did see a significant increase in utilization of these weight management medications. And with use of these medications comes a lot of side effects. We had a significant number of members who had dose-limiting side effects that caused them to have to stop the medication. So in an effort to ensure that our members were properly and safely utilizing these medications, we are making a move to ensure that coverage is limited to those who have a life-threatening condition, which is consistent with the Social Security Act and also the state code. And I'm happy to follow up with additional information if you have additional questions on that.
So Cynthia, if you need more information, drop your email in the chat and Joe Michael will follow up with you. That's all that we have. Thank you so much for all of that information. I learned so much today, Joe Michael.
Good. I'm so glad. Like I said, please feel free to shoot me an email. If you have any questions at all, I'd be happy to answer or at least direct you to the right person. So thank you so much for having me.
Thank you. All right, so next up we have Justin, who finally made it through all of the glitches that he was encountering. Justin, are you on? And Dahlia is going to take us back to the beginning of the presentation so we can pick up your slides.
Yes, ma'am, I'm on. Can you hear me?
Can hear you perfectly.
Perfect.
And so if Dahlia could get that back up for us, we'll go ahead and have you get started.
All right. Just wait for the slides to come up. My apologies for earlier. WebEx put up a fight, but I won. So That is a good thing. All right. So good morning. I want to first start by thanking Natalie and Emily for giving me the opportunity to speak today during the stakeholder meeting. Again, my name is Justin Gist, and I'm the dental program manager here at the Department of Medical Assistance Services. I put together a slide deck taking a look at our dental program with a specific emphasis on our adult dental benefit. I've been with the agency for a little over, yeah, we can stay here. It's okay. I've been with the agency for a little bit over a year and a half. And one of the things that I've come to realize is that many of our agency stakeholders are unfamiliar with the dental program, what we represent, and who we serve. So hopefully this will answer those questions. Our dental team, in coordination with our dental benefits administrator, DentaQuest, continues to work extremely hard around the benefit design and implementation of our dental program. So I'm very excited today to share with you all a few highlights and accomplishments from our program. Again, specifically looking at the comprehensive adult dental benefit. Full disclosure, before I begin, there is a portion of this presentation that I'm going to ask for feedback. So please make sure that you are attentive and have your listening ears on. Next slide, please. So I would like to provide a roadmap, if you will, for today's presentation. And my aim is to answer 3 questions. Looking at our past, I want to answer the question, where have we been? Looking at our present, I want to answer the question, where are we? Finally, looking at our future, I want to answer the question, where are we headed? Next slide, please. So where have we been? Next slide. On April 13, 2005, Patrick Finnerty, then director of the Department of Medical Assistance Services, published a slide deck titled A New Day in Dental. Mr. Finnerty detailed the dental benefits covered for participants enrolled in Medicaid. It's important to note that prior to the Smiles for Children program, a large majority of our children received dental services as part of their benefit package offered by the MCOs. Mr. Finnerty noted that for state fiscal year 2003 in Virginia, less than 29% of all children eligible for dental services actually received any service. Less than 29% of all children eligible for dental services actually received any services. He also noted low provider participation. At that time, 792 providers participated, and continual MCO concerns. As a result of growing concerns around the benefit, the Dental Advisory Committee and the VDA advocated strongly that DMAS carve out the dental program from the MCOs and administer dental as a single program. The Virginia Dental Summit held in September of 2003 recommended that a single vendor be established. After careful analysis, DMAS determined that administering a single dental program is the best means of improving provider participation and increasing utilization. Hence, in 2005, Virginia's Smiles for Children program was established with the goal of improving access to high-quality dental services for children enrolled in Medicaid. 10 years later, Governor Terry McAuliffe introduced a 10-step plan entitled A Healthy Virginia. This plan aimed to increase healthcare services to over 200,000 Virginians, which included dental care to pregnant members enrolled in the Virginia's Medicaid program. On March 1st, 2015, Virginia's Smiles for Children program began providing dental benefits to pregnant members. Most recently, on July 1st, 2021, Virginia's Smiles for Children program expanded coverage for adult members enrolled in Medicaid. Next slide, please. So now that you know that there are 3 programs that fall under the umbrella of Smiles for Children, let's take a look at what's covered under each plan. Our 0 to 20 members, or our children, have access to comprehensive dental benefits, including x-rays, cleanings, fluoride, sealants, extractions, restorations, etc. Our pregnant members have access to comprehensive dental benefits, including x-rays, exams, cleanings, restorative, crowns, bridges, extractions, etc. So I have a question for everyone, and this is not a rhetorical question. Looking at 3 and 4, we see that the adults prior to 7/1/2021 coverage was limited. We only had access to limited exams, medically necessary extractions. So what's the difference between, and this is not a rhetorical question, what is the difference between adult coverage prior to 7/1 and adult coverage post 7/1? I'll call on someone if no one wants to answer.
Oh, Justin, Wendy said preventative care.
Preventative care, right. Great job, Wendy. More specifically, we weren't in alignment with our mission here at DMAS. Next slide, please. So what is our mission here at DMAS? Here at DMAS, we take pride in improving the health and well-being of Virginians through access to high-quality healthcare coverage. Access to high-quality healthcare coverage. Anytime I think of the phrase access to care, I think of 12-year-old Diamante Driver who lost his life when the bacteria from his abscess tooth spread to his brain. He lost his life in part because of the lack of access to oral health care. So that access piece is very important, and the dental benefit post 7-1 aids in improving oral health through access to comprehensive benefits. So what is the importance of improving oral health? Next slide, please. This is one of my favorite slides. It does a great job of summarizing why oral health is a crucial component of overall health. Oral health, ranging from dental cavities to oral cancer, cause pain and disability for millions of Americans every year. The impact of these diseases does not stop at the mouth and the teeth. There's a growing body of evidence that has linked oral health, particularly gum disease, to several chronic diseases, including diabetes, heart disease, and stroke. In pregnant people, poor oral health has been associated with premature births and low birth weight. There is a bidirectional connection between overall health and oral health. We cannot solve our mental health crisis and our opioid addiction crisis without improving oral health. We cannot do it. And I'll give you one quick example. Suboxone is a prescription drug used to treat opioid dependence. So it basically stabilizes someone in withdrawal during the medical detox process and helps them recover from opioid use. Suboxone has a pH of 3.4, meaning it is very acidic. It literally dissolves your teeth. We cannot solve many of the issues that we face as a society without addressing oral health. Next slide, please. So that was a brief history of where we've been, looking at the genesis of the Smiles for Children program, including the purpose or reason for creation, looking at the benefit design pre-July 1st, 2021, and then looking at the benefit post-July 1st, 2021, and also showing the importance of alignment with our DMAS mission. Now let's look at where we currently are. Next slide, please. Comprehensive benefits for adults began on July 1st, 2021. Over 1 million new members now have access to comprehensive care. The benefit model is based on a preventative and restorative model with emphasis on saving teeth. We have and will continue to partner with key stakeholders like the Virginia Health Catalyst and the VDA to improve the benefit and recruit new credential providers. Now looking at our benefit goals, first and foremost being prevention and education, next building around what is salvageable, periodontal maintenance, and also innovative strategies to improve utilization and access to care through member, provider, and stakeholder outreach. Making sure that oral health care is accessible and equitable for all Virginians is a cornerstone of our dental program, again, to make sure that we're actually living our mission and it's not just a statement on our website. Next slide, please. So the first three benefit goals that I discussed on the previous slide have become our mantra, if you will, for adult dental. It's important to note that within our adult dental benefit, all dental specialties outside of orthodontics are represented. There's no annual maximum dollar amount per member, no yearly deductible, and coverage continues year to year while members are enrolled in Medicaid. So now let's take a look at the three pillars. With respect to prevention and education, we realize that many of our members are unaware of the benefits of a healthy oral cavity and how a healthy mouth plays a role in a healthy life. So what we've seen is that some of our members need to be reacquainted to proper health care. Many of our members may have had regular cleanings as children and because of a loss of benefits need remedial education on the importance of sound oral health, which is why prevention and education is a pillar of our dental program. We also want to build around what's salvageable. We want to provide restorations that support longevity, and we also want to extract or remove what works against long-term success. And then periodontal maintenance, which is imperative for gingival or gum health. So I've given you all a lot of information thus far, but now let's take a look at the benefit in action. Next slide, please. So since the commencement of the comprehensive adult benefit on July 1st, 2021, over 160,000 adult members have received a dental service of any kind. Over 87,000 adult members have received a dental cleaning. Over 82,000 adult members have received a comprehensive evaluation. And over 200,000 adult members have received restorative services. But what's even better, next slide, please. If you take a look at this chart, we see that restorations are outpacing extractions. Like we're saving teeth here. Instead of only allowing for extractions, which was done pre-July 1st, we are now allowing members to keep their teeth and restore them with a composite-based tooth color filling. Our concern and our focus is to grow the pro fee, i.e. cleaning appointments, to the level of extractions and restoration, which is why prevention and education was number one on our adult dental pillar. Next slide, please. All right, so I've given you a brief history of the program, but now let's put it all together and let's also include Smile for Children, including our 0 to 20 members, and let's also include our pregnant members as well. So we have over 1.8 million members in the program. According to the most recent Smile for Children quarterly report, over 300,000 children had access to a dental service of any kind during the quarter. 89% of those services were preventative. And according to the most recent Smile for Children pregnant member quarterly report, over 9,000 pregnant members have access to a dental service of any kind. 28.5% of those were preventative. Next slide, please. So where are we going? I think we can all agree that in order to be successful, you have to be forward thinking. So let's look ahead to the future and answer the question of where we headed. Next slide, please. So in the interest of time, I will share 4 of our goals, and I will leave out school-based oral health. I'll leave that out, but I'll share 4 of our goals in order to improve our program. And the first goal is to decrease the percentage of members who utilize the emergency department for non-traumatic dental visits. The second is continual increase in access to care through network adequacy. The third is continual increase in preventive utilization. And then the last I'll talk about, in the interest of time, is the social determinants of health. So next slide, please. So according to the Virginia Oral Health Coalition, Virginia spent $3.31 million on just over 12,000 visits to the emergency department for dental-related pain. That's over $200,000 per visit. According to the ADA's Health Policy Institute, 54% of older adults cited dental care as their second most frequent unmet need. So in response to this, we're in the process of developing an emergency room redirect program with DentaQuest to address the utilization of ED for non-traumatic dental visits. Next slide, please. Our next goal is to improve network adequacy for our entire population, not just our adult members. Currently, we have 1,882 credential providers in the Smiles for Children network. We are paying very close attention to the area highlighted in blue, the Southwest Virginia area. We see much of our member issues around lack of access to care, not only for dental services, but for all services centered in that Southwest region. One of our challenges still is our fee increase. So we have increased our fees by 30% for all covered procedures, and we did that July 1st of 2021. That fee increase brings us to around 80% of commercial rates. And we also acknowledge and are actively trying to change the stigma that surrounds our Medicaid members. We've had and will continue to have internal conversations within our dental team and with our dental benefits administrator around ways to combat member stigma. And I'll speak more to this in a subsequent slide. Next slide, please. So the next goal is to increase preventative utilization. And this is a priority across all 3 programs with a particular emphasis on our adults and pregnant members. You know, within the health space, we're beginning to see a collective push towards including good oral health as a prerequisite to a healthy body. I spoke on the benefits of that oral health plays in overall health earlier, and we want to make sure that all of our members are fully aware of this. Next slide, please. I will briefly touch on this, but I really want to address the next issue that we want to address. But the school-based oral health programs, tooth decay is the most common chronic disease in childhood. According to the most recent VA oral health report card, only 52% of 3rd graders had sealants. So we're working with our partners with the Catalyst to implement school-based oral health programs, also with the Virginia Department of Health to implement school-based oral health programs to help our members access care. Next slide, please. All right. So this is a key reason that I get out of bed every morning and truly love what I do. There's an extremely important yet often overlooked issue within the oral health space. And we have seen, especially in our program, that these issues cause a wide range of health outcomes. But before I begin the discussion on these issues, I'd like to provide some background of who I am and how my past shaped and influenced my present day. I was born in Richmond, Virginia. My mother, who was probably one of the hardest working women to ever grace this earth, had me when she was 15 years old. She worked 3 part-time jobs for the majority of my childhood, but she never missed a sporting event. She never missed anything else I was involved in. We lived in a 2-bedroom, 700 square foot apartment on the south side of Virginia. The housing project that we lived in has since been torn down. Illegal activities, murders, and anything else you can think of occurred in that housing project. My father was incarcerated for 19 years of my life. He was behind bars for trafficking heroin and cocaine. So needless to say that these things heavily shaped my life. These things also shaped my access to healthcare as well. I don't remember going to the dentist every 6 months. That wasn't a priority growing up. So it wasn't until I was much older that I understood the importance of good oral hygiene. And little did I know that many of the issues that I faced with accessing oral healthcare stemmed from my environment. So why is this relevant? There's been a growing body of evidence that has linked certain social factors to health and well-being outcomes. Some of the factors are economic stability, education, access and quality, access to healthcare, stress, exposure to trauma, and the community in which you reside. All these things affect the health and well-being of children, especially in vulnerable areas. I was affected by trauma, economic stability, and the neighborhood in which I was raised. I know firsthand how social determinants of health can affect not only your oral health, but your overall health as well. Many of our members struggle with many of these social determinants of health. Our goal, my goal, is to increase our member and provider education on social determinants of health and how these factors lead to some of the oral health outcomes that we see in Virginia. Next slide, please. So I'm smart enough to know that I don't know all the answers and I don't know it all. If you have any suggestions for our program, please, please, please do not hesitate to reach out to me directly. I'll leave my email, my telephone number in the chat. I'm always open to alternative ways to improve care for our members. Again, thank you, Natalie and Emily, for this opportunity to present.
Thank you so much, Justin. We already have a question for you from Cynthia, and she's asking, can you also discuss how you are working with the MCOs on coordinating that total health care to include oral health?
Hey, Cynthia, that's actually a great question. And that actually just sent out some correspondence to the MCOs about collaboration opportunities, especially working with DentaQuest. We have the Smile and Stork program. That's one of our programs that we do with our with the MCOs, and DentaQuest handles that. But it takes a look at the pregnant members and how we can incorporate oral health into everything that the pregnant member experiences going through pregnancy. We know that we have a strong doula program here. We have a strong program, and we want to ensure that within that doula program, we can also incorporate oral health as well. So that's a great question. And I actually just sent an email to all of the MCOs for a touch point meeting to see how we can better collaborate and ensure that DentaQuest is in the conversations when we talk about oral health as a part of overall health.
Awesome. That sounds good. Sounds good. I didn't see any other questions related to, I think I just see one. Oh, Wendy has one that says, is there a service where families can be referred if they are not connected, or I'm assuming she's asking if they don't have a provider?
Yeah, so and we're actually, that's another great question. We're actually establishing dental homes. So within our Smiles for Children program moving forward, every member within our program will be assigned to a dentist, because what we've seen is that kind of to follow up with that question, there are a lot of members that just they don't know where to go. They don't have a provider to see. They just don't know what to do. So what we've done is we've taken every member and we're assigning them to a provider. So if you're a member and you have siblings, we're gonna try our best to provide you all with the same provider, provided that you all are in the same age range and the provider is accepting new patients. For members or individuals that don't have insurance, we do have a connection with the Virginia Free Charitable Clinics. And I can provide that information for you. Again, I'll leave my information in the chat. And if you want to reach out to me directly, I can provide you that information.
All right. And one last question. Kim is asking, can you talk about a new name for SFC?
Yeah, so we are in the process of changing the Smiles for Children name to better align with the community in which we serve. We are undergoing, as an agency, undergoing a name change to Cardinal Care. So our name will reflect Cardinal Care, and we don't know exactly what that will be, but we are going to align with the agency in the Cardinal Care branding. And we understand that the Smiles for Children is a little bit confusing for some, so we are aiming to align better with the population that we serve and with the agency.
Awesome. If you have any more questions for Justin or Joe Michael, they are going to drop their contact information in the chat for you all. And so we'll make sure that you'll get it there. And then also it'll be in the slide deck that'll come to you after this meeting. And Dolly, if you can go to the very last slide, just a couple of things that we can take care of as we're making sure we're wrapping up the meeting today. Thank you again for your patience as WebEx was having a different kind of day. But one reminder is I have canceled, I don't know how many of the stakeholder meeting calendar invites and stuff, but the last series from last year, that series is completed and it's been canceled. So that link that was used for that bi-monthly stakeholder no longer is in effect. We will send out the agenda, and on the agenda, it will have the link for the WebEx webinar kind of meetings that we'll be having moving forward. So make sure you're on the lookout. Again, that's also a reminder that if you have not signed up for those newsletter updates that we'll send in conjunction with these meetings, please make sure that you do so that you can get that information in a timely manner. Any calendar invites or anything in Teams is weird. I was talking to our tech team about that this morning, about not deleting things from people's calendars. So if it's on there and you see anything related to that old series, please go ahead and delete that from your calendar so you're not getting confused about that particular date. Also, if you have any topics that you'll be interested in learning more about as we continue to schedule these meetings, please do not hesitate to send them my way. Me or anyone on our team will be happy to receive those suggestions so that we can continue to work forward and try to make sure we incorporate the components and the subjects that are interesting to you as far as us moving forward. We'll be also making sure that you all we've talked about this a few times before, last year and a couple of other times, about trying to incorporate stakeholders and giving them an opportunity to share some of the things going on within their organizations. And so we're going to be picking up that idea as we move forward as well. And if you're interested in serving in that capacity or sharing your information from an organizational standpoint during these meetings, don't hesitate to send that information directly to myself as well. And we'll make sure you have the contact information for me or any of our team members when we send the follow-up information. As always, we thank you so much for being with us today. We thank you for taking the time out of your, I know, very, very busy schedule to hear about the different services and updates and opportunities that exist here at DMAS regarding outreach engagement and across the entire agency. And if you have any other further feedback or questions, we're always here to listen. So with that said, Dahlia, myself, as well as Sonia, thank you for joining us today. And you can definitely drop any questions that you have as a parting gift for Justin or Joe Michael. And we'll see you next go around. So thank you all so much. And the minutes and the recording of this meeting will be placed on Town Hall, so you can always refer back to it if you need to. All right, y'all have a wonderful day. Thanks for joining.